Yes,
Hello.
yes.
Okay. So thanks, Sarvindan. And on behalf of my other co-host, Nidhin, who graciously agreed last minute, who is also a physician in Médecins Sans Frontières in Mumbai, Maharashtra. Thank you, everyone, and really warm welcome to all. Though I'm desperately waiting for rains to cool the earth, and especially in Gujarat here, and some hearts as well. So today we have a stellar and diverse list of resource persons who are giving their precious time for us. We have a range from people with decades of experience to freshers, and from various professional backgrounds and also from different geographies. So all the attendees today, we all are very fortunate to have this panel, and we should try to make the best of this opportunity. So I'm not going to waste more time. So I must acknowledge some of my friends are currently doing a Jal Yatra in some parts of Jharkhand villages for land, water, and forest rights. So in solidarity with them, I will ask Ruth to begin. Ruth Moses, she's from CMC Vellore. She's doing her bond there after her MD in internal medicine. And she's going to talk about a very important aspect of health, on what lens we should use when we see health and well-being, and this should be the basis for any kind of a physician or healer. So over to you, Ruth.
Am I audible, ma'am?
Yes.
Okay. I'll share my screen.
And I'll just remind the speakers, I'm going to remind people at minute 10, and then you have 2 more minutes after that, yeah?
Okay.
Should
I start, ma'am? Is my screen visible, ma'am?
Yeah. For me,
okay.
Yes, I'm hoping it's the same for all ends.
Okay.
Yes, it is, please, yeah.
Okay. Hello, everyone. My name is Ruth. I am a junior doctor in CMC Vellore. I am going to share my perspective on social discrimination and its impact on health from the perspective of someone who is working in CMC. And I would like to thank Dr. Anand for guiding me through this presentation. So this is a news article from the Economic Times where they said that 1 in 4 Indians face discrimination in getting healthcare services, and that may be due to their caste, due to religion, because of their illness as such, or because of the other health conditions that they have in the hospitals or by the healthcare professionals themselves. So this is a major problem which we face today. So in this small presentation, I would like to focus on who are the socially marginalized in India, what are the factors which affect their health, what are the particular health problems among them, and what are the difficulties in health delivery and access that they face. So social discrimination is a very broad term. It's a sustained inequality between individuals on the basis of any measure of diversity. It can be race, it can be gender, it can be social status, many different things. In my presentation, I'm going to focus on social discrimination based on marginalized part of the society, which includes the scheduled caste, scheduled tribe, and other indigenous groups of population. So according to WHO, what are the determinants of health? Determinants of health according to WHO are divided into structural determinants and intermediary determinants. Structural determinants are the socio-economic and political condition of the country, that is the governance, policies, the values which are inculcated in us from childhood, and the socio-economic standing of that person. That is, what is their education, occupation, income, how they are treated in the society, do they have social equity or not. All these affect the intermediary determinants, which includes their housing, food, and sanitation, and this finally affects their health and also their access to the healthcare. So I want to highlight this point by one case. This is Mr. Kashi, a 53-year-old farmer from Javadi. He presented with history of multiple episodes of loose stools, watery, large volume for 3 days, and decreased urine output for a day. He was very dehydrated on examination. His heart rate was very high. His blood pressure was low, 80. He had respiratory rate of 30 per minute. He had an acidotic breathing. Other system examination was normal. So at that time, diagnosis of acute gastroenteritis was made with dehydration and probable acute kidney injury. But what is the bigger picture? What the medical curriculum teaches us is how to diagnose patients and what is the pathology of the disease. So we know that this patient has gastroenteritis. Probably he got it through contaminated food and water. But what the medical curriculum doesn't teach us is why this particular patient and many multiple patients like him are getting gastroenteritis. So let us focus on Mr. Kashi for some time. Where is Mr. Kashi from? He is from a place called Javadi. So Javadi is a area which is in Eastern Ghat mountain area, which separates Vellore from Tiruvannamalai, and its distance from Vellore is around 112 kilometers by road. This is an area where a lot of tribal population stays. So if we want to know why this patient developed gastroenteritis, we should know what is the water quality, sanitation, and hygiene among the tribal community which is living in Javadi. So this is a small study which was done by CMC in 150 households across 6 villages in Javadi, and they wanted to assess the water, sanitation, and hygiene practice among the tribal population in this area. So they interviewed a lot of women, mostly women who were taking care of the household. They were many people, 74% were illiterate. Most of them were living in kacha houses, and they were of the lower socioeconomic status. So they assessed a score called WASH score, which had 3 parameters: drinking water, sanitation, and hygiene. Under drinking water, they wanted to see, are they trying to purify the water that they have? How are they storing water? And what do they use to draw water? Sanitation, they tried to assess how many people use latrine. And hygiene, they tried to assess whether they would wash their hands, use soap, or whether they would bathe regularly. Maximum score possible was 8, and less than 4 was considered as a poor measure of sanitation. So the results of this study showed that most people were using a bore well. They were storing the water in metal pots. They were keeping it covered. However, the purification was being done in less than half the people. 57% of the households did not use any purification method. They also found that to draw the water from the container, they would use a tumbler. So their whole hand will go inside the tumbler while drawing water out from the storage container. They would not use a tap or a small can for it. And they noticed that 99% of the households practiced open field defecation. So this gives us an idea of why this particular patient might have developed gastroenteritis. So in this social determinant of health, we understand that there are multiple factors, including this patient's housing, his sanitation, the water supply, as well as education, income, his ability to get a house with all these facilities that have affected his health. This was just one example of such disease which affects the socially marginalized. However, socially marginalized suffer from so many more challenges. Not only communicable diseases, vector-borne diseases, non-communicable and hereditary diseases, and occupational diseases have caused problem in this community. So there are so many papers which highlight this problem. I will give only 2 examples of communicable diseases. One was a study which was done in Madhya Pradesh. Here they found that the prevalence of tuberculosis was almost double in the tribal population versus the non-tribal population. Even though it was double in them, only 11% people were getting treatment based on smear report. Another such example is malaria. So more than 60% of the falciparum cases and as much as 50% of mortality associated with malaria is seen in the tribal population. Similarly, for non-communicable diseases, there are so many papers which highlight this problem in the marginalized. For example, they have a higher incidence of hemoglobinopathies. Children have more incidence of being underweight. And there are 77% children seen in this study who were anemic, and 38% had helminthic infections. The tribal men have higher incidence of use of tobacco and alcohol, and therefore more chance of getting non-communicable diseases. So now we understand what all problems these people face, and in a much higher measure than the non-marginalized. So let us go back to the case. What happened to this patient? This patient in the hospital was treated for diarrhea. His stool showed Vibrio cholerae and he had an acute kidney injury. However, on rounds, an attending doctor has said, "Don't you know you should have come to the hospital immediately if you have loose stools? Why did you come so late when your kidneys are getting affected and you may even need dialysis?" So what does this tell us about what barriers this patient might have faced to get healthcare, and what is our attitude when we are trying to take care of the patient? So this is another study which was in Telangana. It highlights the problem of access to healthcare. Could this patient have accessed healthcare? Maybe it was not so easy for him to come to the hospital and therefore he came very late. In this study, which was done among tribal women, they found that the first place where most women go is to a government health center. Very few of them go to private hospitals. And the minimum distance which they have to travel is at least 5 kilometers. However, 40% of them have to travel at least 15 to 20 kilometers to reach the nearest private health center. And as I told earlier, Javadi is actually 112 kilometers from here, quite far from here, and it takes a long time to come by road, which may not have been accessible to this patient. So in this health delivery system, the first point of contact is most important. Where did this patient probably first go? To a primary healthcare center. So I want to highlight this by another case. This is Miss P from Balaja. She presented with history of headache for 2 days, blurred vision for 2 days, and feeling drowsy for a day. She also had fever for 2 days. On examination, she had a rash over the palm and sole, a purpuric rash. I think the picture is not very clear. She had absent perception of light in the right eye. She also had a hypopyon in the right eye and corneal congestion. There were exudates on the iris and pupil. Signs of meningeal irritation were present. So clinically, a diagnosis of acute meningoencephalitis was made and probable right eye endophthalmitis was made.
Arvind, we lost him.
I'm here. I'm not sure if Ruth may have got disconnected, I think.
I'm going to try and call her. Sorry for this. Okay. So she had 2 minutes to go after that. Let's see, maybe should we go on to the next person then, or wait, take 1 more minute?
In case if Dr. Anand would like to, conclude this.
Complete it.
May I suggest that I think she's reaching the end, which is important. She's raising some questions. We can come back to her.
Yeah.
So that she can conclude properly.
Okay. I tried calling her, but maybe
she'll come back. So
the internet has gone or something.
Yeah.
Okay. So, so we can. She back.
I'm so sorry, my computer suddenly switched off, ma'am.
Okay, go ahead. Yeah, that's okay.
Continue, ma'am.
Yeah, of course.
So this patient, I'm really sorry. My computer switched off suddenly. I'm sorry for the delay.
No problem. No issues.
So this patient was diagnosed with acute meningoencephalitis and a right eye endophthalmitis. Finally, by culture, we knew that this patient had Neisseria meningitis, which is actually a fulminant form of meningoencephalitis. So where do you think this patient went first? What was the first contact of care for this patient? She first went to the primary healthcare center, and the first contact was the doctor there. She received the first dose of antibiotic within 15 minutes of presentation, and she was referred in a timely manner. So this not only saved the patient's life and her vision, but that early recognition of such a fulminant disease was made and the correct treatment was instituted, which is the reason why her vision and her life was saved. So what is our attitude towards the people who come to us for healthcare? Do we treat them differently? There are multiple newspaper articles which highlight the problem of discrimination based on amongst healthcare providers. There was a newspaper article in 2013 about a tribal woman who delivered at a PHC in MP. Nobody came to care for her after she delivered, and she was not even given a bed to be taken care of. Another incident was highlighted in the newspaper article in Hyderabad in a clinic called Kepal Clinic, where there were so many tribal people going to see a MBBS doctor there. When asked why they chose that specific clinic to go, they said that when we go to a bigger hospital, usually the doctors look at us like they don't want to touch us, they don't talk to us very nicely. So if our behavior towards them is not very good, do you think they will trust in the healthcare that they receive at these healthcare centers? Maybe not. So in summary, I just want to say that first point in addressing this issue is self-awareness. Being aware that we ourselves have, in knowingly or unknowingly, discriminated against people who have come from a different social background. So while I was making this presentation also, when I was discussing with Anand sir, I kept saying these patients, them, they, and unless till he told me that is actually like you're discriminating, you're telling you are different and I am different, I did not realize what I was doing. So first point is self-awareness. Second is, even though we study in our curriculum, we study community medicine, we study all the subjects, we don't acknowledge this invisible problem of discrimination and how it is affecting health. We realize it much later when we start practicing. And we fail to understand what are all the aspects which affect a person's health, social factors, physical factors, what barriers they have towards healthcare. So I want to end this presentation by leaving some questions with you. In your day-to-day life, in what way do you see discrimination happening? How should we be more conscientious of discrimination? And at the end of our training, will we be equipped or sensitized to the problems which are faced by the marginalized? And what can be included in our training to help us be more sensitized? What can we as students and young doctors do towards reducing discrimination? Thank you.
So, thanks, Ruth. That was a very important presentation and set the stage, and I hope set minds thinking, people who are here. In fact, very recently, one of the travel fellows, there's a rural health travel fellowship program in which some 10 centers participate. Devadasan shared a very similar story from Odisha about how reluctant the people from the villages were to go to a higher center because of this very reason, the way they are treated. Similarly, I had an experience when I was in Tamil Nadu, where we even forget to put a screen, while examining patients. If they look different, dress different, speak different, then something, the second nature of even putting a screen before examining, that is also a sign of respect, I think. You also remind me of, there's one quote of Mahatma Gandhi which says, recall the face of the poorest and weakest whom you may have seen, and ask yourself if the step you contemplate is going to be of any use to them, and will they gain anything by it, and will it restore them control over their life and destiny. So for every step, I think we should be conscious. So thanks a lot. For the attendees, if you have questions, please put them in the chat box, and we have the Q&A session at the end of all speakers after they finish, and you may address it to a particular speaker as well. Yeah? We have 4 more to go. So the next 2 speakers, I'll introduce both together. Dr. B.C. Rao is from Bangalore, Karnataka, who has been a family doctor for over 5 decades, a mentor and teacher in family medicine, a former president of the Association of Family Physicians in Karnataka. And I'm also going to mention some hobbies of our speakers, only to tell people that, sometimes people think that those who are in primary care or family medicine or rural health, they are quite boring, and there's nothing beyond sorrow, misery, and things like that. It's not like that. So his hobbies, which span more than his medical hats and feathers, are golfing, writing, reading, birding, travel, nature, and he says most importantly, worrying about climate change and boring people from talks of the past. That is Dr. B.C. Rao. Then we have Dr. N. Devadasan, also from Karnataka, also from CMC Vellore. He has worked with Adivasis in the Mudumalai forest for over 10 years, doing a mix of community medicine and hospital medicine. He then joined the WHO at Delhi and was responsible for establishing the IDSP, or the Integrated Disease Surveillance Program for India. Then he got fed up with the WHO bureaucracy and founded the Institute of Public Health in Bangalore, IPH. Today, there are more than 30 public health researchers who conduct public health research, teach, and also try to change policy. In between that, he has completed his MPH and PhD, also has published over 100 articles, and his interests are Carnatic music and reading. So over to you, Doc. That's Dr. B.C. Rao. That's what he likes to be called.
Yeah, thank you, Vasundhara. Now, quite a number of you I heard are young doctors or medical students in search of what should be done after you finish your degree, or after you finish the job that you're in, and then what life you should lead, and what branch of medicine you should take. See, what happens to most of you is institution training involves exposure to multiple specialties, but not family medicine and primary care. Now, not being exposed to this branch of medical activity means that you miss out on a very important, career path, which would otherwise would have been your choice had you been exposed to family medicine practitioners. The idea that I am today here is to give you a glimpse of what family medicine is all about. And being in this field for over 50 years, I think I have a bit of authority to do this. Can you see my slides?
Yes, I can.
Yes, sir. Yeah.
You're able to?
Yes.
Okay. Why family medicine? The reason why family medicine is that, family practitioners actually work in the community. Years ago, that was one of the choices that we had and we made those choices because these specialties were very few, and then willy-nilly we were forced to take up family medicine. And those days, doctors who did their MBBS were reasonably well trained to practice medicine and family medicine in the community. Today, what's happening due to increased exposure to specialties and subspecialties in hospitals and medical schools, what's happening is most youngsters don't think of family medicine as a career path. Most of them go to these branches of medicine, and I have personal experience of many youngsters being very frustrated because the working conditions are such. Private medical care and hospital care today is not very satisfying for very many reasons. And my job today is possible. Am I audible? Can I go back to that previous slide? Okay. So this is a much needed specialty because there are not many who are practicing this specialty today in the community. And it is community based in the sense that you don't really work in the hospital atmosphere, but you work in a community atmosphere surrounded by your own people who are like you. And to a great extent, the previous speaker who talked about social determinants of health, you will yourself come to know and practice it, and you will know your people, and you are better accepted than a hospital-based doctor by the community. The other aspect of family medicine is, you are an effective gatekeeper in the sense you handle all problems of all specialties, and you decide who needs a care which is different from what you're giving or which you cannot provide. So to that extent, the patient is, you are the first doctor who sees the patient, and then this kind of activity will saves the patient a lot of time, money, to him and his family. And he has an access to fairly comprehensive round-the-clock care from the practitioner. So he has access during working hours and access in non-working hours on telephone. So he gets a kind of an attention which he cannot get in the hospital-based practice. Okay, can I have the next one? Yeah. Can I have a fresh graduate who is MBBS just out of his internship begin family and medical practice? My interaction with a lot of young doctors today, I have found them really not going through their internship and house surgeons as they should, because most of them are, this time where they should be learning the skills of practicing medicine would be spending their time in preparing for their entrance exams. I'm not saying that you should not do it, but then the very valuable time of your life is lost in preparing these exams, and you never know which specialty you get and where you're going to go, whether you're going to get any specialty position or not. If you get, where you're going to get. There are so many ifs and buts that you're going to face. And we know that the number of seats that are available and the number of doctors who come out is absolutely, that has no relation to one another. Many of you are left high and dry without a recourse to any specialty. And family medicine itself now has become a specialty. So can a fresh graduate, I don't think today's graduate, not our days, can begin medical practice without further training. Where he can get this training? So can I have the next slide? So by doing various channels of training are available. the best would be to do a 3-year DNB or an MD or certificate courses like MEd, which does Vellore does it, and other certificate courses are run by various other organizations. And by working in a charitable hospital, mission hospital, or even a government hospital in districts, by working in emergency and casualty departments, what happens here is all kinds of patients come to these departments, and then you will be you'll get training in various aspects of general practice or family medicine by working in these casualty or emergency departments of bigger hospitals, and by working in PHCs. Actually, our PHCs are major, very good training centers, PHCs and CHCs. And recently there has been a decision that to place MBBS doctors with DNB and postgraduate training to work in our CHCs. It's a good move. So working in these places, you get the skills that are required to become a good general practitioner or a family medicine practitioner. Can I have a next slide? Yeah. So what are the big advantages we have in being a family medicine doctor? You see, for family doctors, there's no retirement. Even at my age, I have to practice because my patients don't leave me. Even if I want to, I cannot leave. So as long as you want, or your patients want, you can work. And second is another important is there is a financial and ethical independence. Financial independence in that, you see, you are your own master. Your earning is your own. And then is there a limit? It depends on your kind of work you do and the nature of your work and the extent of your work. The ethical independence is another important aspect of your life. See, here there is an opportunity to practice ethical medicine. I don't say that others in institutions do not practice ethical medicine, but there are a lot of constraints in which they work. My personal knowledge, a lot of doctors who are working in corporate hospitals and institutions are bound by rules and regulations which sometimes do not allow them to be ethical. So here there is no such compulsion. You are your own and it is eminently medicine. Then you have a long-term relationship. It's a very important aspect of family medicine is that you become a doctor to generations of patients. So the trust that you have in you is a very important aspect of your life, and your patients will come to trust you. And then, I sometimes tell, we general practitioners get away with murder jokingly. That means they are very forgiving to your mistakes too. Mistakes I don't say that don't occur in our practices, it does occur. But then they take it, with a lot of kindness and fortitude and forgiving to us. Then there is, because of this relationship, there is less chance of litigation. In my experience, I have found very few in my own circle of family practitioners getting involved in litigation. Of course, we'll have to go to courts and sometimes we'll have to give evidence, but then it is not that we are not legally involved in something that we have done a mistake, therefore a patient takes us to court and that kind of litigation. This practice also, because it is your own time, you can spare time to be with your family, to have a holiday, your friends, you can have a circle of good friends and other useful hobbies and activities you can develop in your life, which makes your life wholesome, and you will be a very rounded personality. I tell you, it's extremely important that you develop these interests in life. Life becomes more meaningful, and it will be a pleasure to be a doctor if you have these interests, if you can develop. The last one, yeah. I have not really given you the examples of patient care, which extensively I have written in my blog. And also I have, in my published articles, I've given you a number of examples. So I'm sorry I have not put up all those, but I think you should be able to do net search and find out. And all aspects, such fun that, I won't say it's not all fun, but it's a lot of fun, pressure, and occasionally you suffer with your patients, because after all, medicine is not a specialty wherein you deal always with happy people. See, people with suffering, people with terminal illness, serious illness, if you are looking after them, a part of that suffering, naturally you are involved and you also suffer with them. That is inevitable. If you want to be a good family physician, some pain you will have to suffer. But overall, your life will be extremely satisfying if you take up this specialty. Many have asked me, there is a lot of money in super specialization, and family doctors don't make that much of money. True. But I have got my young friends who are super specialists. Believe in me, they are not extremely happy people. Some of them may be, but many of them are unhappy people. Money is not everything in life. And family doctors do make a good amount of money. It's not that we are starving. But then if money is not end all of life. Vasundhara, I have come to, I think, the last slide.
Yeah, I'm not.
I think I've also run out of my time.
Yes. Thank you.
Thank you. Thank you for giving me this opportunity.
Thanks a lot. So, so again, it reminds me of one more quote, the last things that you said, especially another one of Gandhi's quotes, which says, "The world has enough for everyone's needs, but not for everyone's greed."
That's right.
So with that, we'll go to our next speaker, Dr. Devadasan, who's going to cover a broader aspect of healthcare. Okay, are we ready? Thank you.
Hello, can you hear me?
Yes.
And you can see my slide?
Yes.
Yeah, so thank you, Arvind and team, for inviting me to share some of my thoughts on primary health care. My journey actually began 35 years ago when I went into Gudlur, Mudumalai forests and started working with these people. And initially, after MBBS, I was planning to become a pediatrician, and my wife was planning to become an obstetrician. The usual, this thing, what's that? Specializations for a couple, and we were planning to start up a hospital in Kerala and earn money, quote unquote. But when we started working here, we realized that these people had tremendous needs, which even an MBBS doctor could provide. You don't need a specialist, you don't need a surgeon, etc. Even an ordinary MBBS doctor who can provide good care was good enough for them. And that's how my wife and we both got involved with community health, bar primary health, etc. Today, I'll just quickly go through why. Dr. Rao has already mentioned it, but I'll just give you some other this thing, and what is primary health care and how can you do it. So why primary health care? This is actually, I was inspired during my medical college days by my professor of community medicine. He shared with us a story from China. Apparently, like China in those days, I'm talking of 12th and 13th century. Those days, patients used to go to the local healer and would get cured and would give something, either money or something in kind, to the healer or doctor. The king at that time was very perceptive, and he realized that sometimes people can't approach these doctors and healers because they did not have money, or they did not have a chicken or a goat to pay to the healer. So what he did was he announced in China, he said, from now on, I will pay each of the doctors, bar healers, a certain amount of money, a fixed amount of money every year from my treasury. In turn, you will provide free care to everybody from this amount of money. So if I give you whatever, I'm just taking an example, 1 lakh rupees for a year, you have to treat your patients, and which includes your consultation fees and your medicine costs, etc., from this 1 lakh. Now, what happened was that it changed the behavior of the doctors, because the doctors wanted to keep as much of that 1 lakh as possible. So they switched from treating patients to making sure that patients remain, individuals, communities remained healthy and not become sick. What we would today call preventive medicine or promotive medicine. And that's how the system grew in China. After that, of course, it fell through because of various reasons, but it really inspired me because it said, this is what a doctor should be doing. We should be talking about health. We should be talking about wellness, not just treating patients and illnesses. So that was one mindset which brought about a change. And subsequently, when I've been reading, etc., there is now evidence that primary healthcare, wherever countries which have strong primary healthcare have better health outcomes in terms of infant mortality, child mortality, adult mortality, even mortality due to cardiac conditions, are better in countries where there are strong primary healthcare. They, of course, have improved access to healthcare because primary healthcare is usually decentralized. People, the health center or the doctor is closer to their residence than a hospital. And evidence is clearly available that a lot of hospitalizations, especially in the Indian context, unnecessary hospitalizations can be decreased if we have a strong primary healthcare. Now, what is primary healthcare? You may have heard of, read in your community medicine, Almata, etc., etc. After going through various things, I have broken it down into 4 characteristics. One is personal healthcare. The second is population healthcare. Third is addressing the social determinants. And 4 is empowering communities. So I'll just take quickly each one of them. So personal healthcare, we usually think of primary healthcare as only preventive medicine. Okay, we will go and educate the community. No, actually, the prime need of a community is curative care. And that is something that a primary health care physician has to provide. So in Gudlur, when we started, we also went in because we were taught preventive healthcare is the best, etc. And then we realized that the people, they were saying very clearly, you first treat my stomach pain or you treat my headache, then you talk to me about vaccination or my child's vaccination. You take care of my fracture, then we can talk about smoking, stopping my tobacco use. First, my need is important. And that's something which really stood out for me because we had come from a community medicine background in Vellore where we were taught primary healthcare is equal to prevention. And here was the people telling us, no, our needs are curative care. And that's what really struck us. And today, I think slowly the government is many people in primary healthcare are realizing this, but yeah. So one is, so you provide personal healthcare, and here I would like to emphasize, it is not basic healthcare. It is not ORS for diarrhea or gentian violet for some sores, etc. It is essential care for the community that is living in that catchment area. which means that it may include a cough and a cold, a small thing, but it may also include appendicitis. So if a patient comes with stomach pain, right, iliac fossa pain, it is the responsibility of the primary care physician to identify, diagnose it clinically, and then refer it to the hospital for surgery. In our country, what happens is, because we don't have a very strong primary health care, patient goes directly to the hospital, and then if they go to the surgeon and this thing, then fine. If they go to somebody else, so if it's a woman and she goes to a gynecologist, the gynecologist will say, oh, you've got DUB, or you've got pelvic inflammatory disease, here, take some antibiotics, and diagnosis is delayed, etc. And then finally it becomes complicated, and patient suffers a lot. Whereas if you had a good primary healthcare physician, that person would be able to make this diagnosis and refer the person to the correct, appropriate hospital. Yeah, primary healthcare, we have heard all this: accessible, available, etc. But here I wanted to highlight one aspect, which is comprehensive care. And today that is what is missing in our entire Indian healthcare system. Just the other day, my wife was not well, and she was referred to she had some breathing, this thing, so she was referred to a pulmonologist. Pulmonologist examined her and said, okay, you need to do XYZ tests, but you also need to get consulted with a cardiologist. So then we went to the cardiologist. Cardiologist also said, okay, so much these things, all these tests, echo, etc. And then finally he said, in between, she said, oh, my back is paining. Okay, now you go to the orthopedician. And so like that, every single organ, whichever she had problem with, she was being turfed from one specialist to the other. And no one was looking at the whole, her as a human being, as an individual. Whereas people want that. People don't want to be said, okay, for my eye pain, I have to go to one doctor. For my ear pain, I have to go to another doctor. For my leg pain, I have to go to... People want a doctor who looks at them in a comprehensive, as a human being, not as an organ. And I think this is what is missing. And primary healthcare, as Dr. Rao said, family medicine. This is where the core of family medicine, where we talk of comprehensive care. Now, other than personal care, we also talk about, in primary healthcare, there's an additional three elements. One is population health care, which is, people come to me for treatment, but I also, or my team goes out maybe to screen the school children for this thing, what's that, problems with their eyes, refractory errors, or hearing errors, these things. Or we do surveillance. Oh, we see a lot of fever case coming up. I'll alert the government saying that, hello, in my area, there are a lot of fever cases, so they can take action. In fact, in Vellore, I don't know whether the current generation of Vellore students or this thing have, Vellore, in that Kanyambadi block, this thing, they use private practitioners as the first surveillance system in the country. Private practitioners every week would send a postcard. That time it was 10 paisa or something, saying if they saw any measles, if they saw any fever with rashes, etc., polio, they would just write on that and it would post it to Dr. Jacob John and Vinohar Balraj, and they would then go and investigate. So surveillance from the primary care became a very important thing, can especially in this COVID times, can be very important. Then of course vaccinations, other preventive services, etc., all is part of this population health care. The idea is that I take responsibility for the health of this population, not just the diseases, but also the health of this population, preventing as much as the diseases as possible. Then of course, if you're a very good primary healthcare physician, you will also get involved in the other determinants of health, because you know that just by giving medicines, it's not enough. Like Ruth mentioned, if diarrhea is a problem, Where are they getting their water from? Can the government provide them with piped water? Nutrition. Why am I seeing these malnourished children? What about the ICDS? Can I link up these parents with the Hello? Yeah. So this sort of connections can easily be made by a doctor sitting in a clinic, because a doctor at a clinic has tremendous power in terms of welfare of the patient, but which we never use it. I remember when we were talking about nutrition, we had just to call up the revenue RDO, revenue this thing officer, and say, hey, this is happening, can you do something in this village? And they would be very happy to do it, just because I was a doctor with this thing. Then of course, community engagement, I'll talk about this much later, but
sorry, Dr. Deva, you
just
have
last
2 minutes.
last two slides. Yeah.
Thank you.
So how is primary care provided? It's either by single doctor clinics or a team of specialists in family medicine. Recently, there's a shift from doctors to nurses, and usually primary care physicians are responsible for 1,000 to 10,000 individuals. In most countries, primary healthcare services are funded by the government. And this is the map of the globe, where the red color is the primary healthcare services are strong. The orange is where it is kind of middling. The other gray area, I do not have the data, so I'm not put it. But look at it globally, primary healthcare is the foundation of your healthcare services. So my question to all of you who are deciding what specialization to take, are you willing to consider primary healthcare via MD community medicine or via family medicine as one of your options? Thank you very much.
Yeah, thanks a lot. Sorry to rush you like that. So that's one session. I liked what Dr. Rao said, the effective gatekeepers of the system, so that we also tying it with what Dr. Deva said, that we can reduce the burden also. This is one more thing. We can reduce the burden on the secondary and tertiary level centers, and they can stick to their specialty. Otherwise, we lose quality at every step. And we saw this in COVID, actually. Countries with good primary healthcare systems did much better. And I'm hoping that the push for digital health and AI doesn't take whatever life is left of medicine and the human being. We are already chopping the human into different parts. And now with, we look up to digital health as if that's the answer to health and well-being. Anyway, so thank you both. We'll move on to the next set of speakers. We have another exciting pair. I hope it's not intimidating the bios. This is only to show the newcomers that one doesn't have to be fixed, and everyone started small and have diversified into different things. So Shyamsundar, our next speaker, is from Gujarat. He is in his mid-career phase, he says, a community physician and a family physician in training. After completing master's in 2011, he worked for almost a decade at a rural medical college in Anand, Gujarat. He designed and implemented a rural community-based comprehensive NCD, or non-communicable diseases prevention and care program named SPARSH for 150 villages. He has also worked with the state and national government and the NHSRC for starting an innovation and learning center to support the rollout of health and wellness centers. He has undertaken several population-based studies in collaboration with national and international agencies. He quit his job in January 2021, and I don't want to tell who was responsible partly for that, and took a gap year and to explore rural India. with his 7-year-old son and physiotherapist wife, Apeksha. He is currently pursuing PGDFM from CMC Vellore, in addition to also running, he has recently joined an NGO, Bansali Trust, in the tribal district in southern Gujarat, to work on improving primary healthcare delivery in over or close to 100 villages. Again, his interests are cycling, trekking, adventure sports, and exploring new places. So that is Shyam. I'm going to introduce Sejal also, who is the speaker in this session. Sejal is from Maharashtra. She has a background of an academic background of MD Physiology. She has worked in Uttarakhand with Helpage India for Kedarnath floods. Then she moved with Karuna Trust to work in primary healthcare centers in Arunachal Pradesh and Meghalaya. While at the PHC, she did her M.Med family medicine offered by CMC Vellore. We have a lot of CMC Vellore influence in this, I see. And then she got an opportunity to work in Antarctica in the Indian Research Station there. And while there, she did her fellowship in diabetes, again from CMC. And currently she works with MSF, or Doctors Without Borders, in Mumbai in a drug-resistant TB project. To update her knowledge, she did an online course and diploma in tropical medicine and hygiene offered by MSF from London. Okay, so those are our last speakers. So over to you, Shyam and Sejal. I think Shyam goes first. Thank you.
Thank you, Vasu, and thank you, doctornet, for giving us this chance to talk in this platform. And thank you for all the participants for joining me. I hope you can see my slide and you can listen to me. Hello.
Yeah, we can see and we can hear you.
Okay, thank you. So me and Sejal are going to talk about this dilemma which is faced by many of us, like whether to be a generalist or whether to be a specialist. So a few things I would tell before we move on to this session. So one thing is that when we are talking of generalist or specialist here, it is not a particular degree, like it's not whether it is family medicine or community medicine versus a surgeon or a pediatrician or gynae or a subspecialist or super specialist in this. It is not like that. What we are going to talk of, what we are going to talk of is like the concept of a generalist and versus a specialist. So it is possible that a person is trained as a neurophysician and he practices general medicine or sees gynec patients, or it is possible that a person is trained as a gynecologist and he operates appendix, he treats MI, and he treats skin conditions and whatnot. So, and actually these are not hypothetical situations. I know people who are doing this, and I'm sure many of us would also be doing. So it is the approach which you take in your practice or in your profession or in your life which matters. Whatever be your degree, might be a specialist or a GP or whatever you are. This is the approach which matters. And our talk today would be like, how does one come to the decision, like what he wants to be. We are not here to sell being a physician or a family physician or community medicine. It's like, how do you come to that decision to whether you want to be a generalist or specialist? So that we'll talk of. So what we'll do, we'll share some facts. I'll start the presentation. We'll share some facts of the current situation of medical doctors in India. Then we'll talk of an approach by which a person can decide on a career choice. Then Sejal will talk of her journey of what she did over the last few years. Then I'll also talk of my journey. And then we'll conclude like which is a better choice. So with that background, we'll just start. So this is the current situation of medical doctors in India. Like every year, there are 90,000 medical graduates which pass out, MBBS doctors which pass out. And the government has the target of taking it to more than 1 lakh. There are 45,000 postgraduate seats, so 50% of there are 5,000 subspecialty seats like MCH or DM or whatever you can name it. So these are how the numbers work. So you can imagine the kind of competition. So if you miss out on a year, and when you have to compete on the next year, we will have a new cohort appearing for the NEET PG, and then there are many scenario of subspecialty seats. It is a bit of worry. Dr. B.C. Rao mentioned so the subspecialty, but I use the word subspecialty because I think that is more appropriate, because they are focusing on some part of a specialty. So recently, this is a very recent news item in this month itself. So the government, there are around 5,000 seats, as I said. So there were 2 rounds of counseling, and there was 1 mop-up round. Even after that, around 2,000, if I remember correctly, around 1,500 to 2,000 seats were lying vacant. There were no takers for the seats. So the government had to reduce the cutoff marks for people to get the seats, and there is a second mop-up round being planned. So I talked to someone who is closely observing this thing, like why is it so? Why are people not so keen on taking subspecialty in spite of there being very less subspecialty seats? So according to her, there are many issues. Like there is a 3-year bond. People don't earn in the initial period as much as they would have expected, and then in the urban areas, there is a lot of saturation for subspecialty already, and nobody wants to go to the rural areas. Then there are many subspecialties where even a physician or a general practitioner can manage the patients. Say, for example, rheumatology or in some way endocrinology, diabetes, and other things. So there are many of the conditions which even a physician or a family physician can manage. So because of this, there is a less interest in people for doing subspecialties. You can check it on your own. I'm just sharing facts. This is not what I think. It is about what is the current scenario. And this is the current scenario of doctors in the community. WHO recommends a population doctor ratio of 1:1,000. So for 1,000 people, there should be 1 doctor. So in the best performing states like Tamil Nadu, Delhi, it is the ratios are very good. Actually, if you see 253 people per doctor in Tamil Nadu, that is the highest probably. And at the same time, there are states like Jharkhand, which has 8,000 population per doctor. So there is a lot of problem in those states. And at the same time, if you see the rural scenario, rural urban scenario, those numbers which you see here, those are averages. If you segregate them into rural and urban, then the situation is a bit worse in rural areas. In urban areas, 75% of the dispensaries, 60% of the hospitals, and 80% of doctors are in urban areas. So in the rural area, there are only 20% of doctors, whereas the population of rural India is 65%. So you can easily see the divide. So these were some facts of the current scenario in our country of doctors. So you can keep that in your mind when you're choosing. Now, this is a bit philosophical and a bit something which you need to think about, like how do you make a career choice? There is a very good book I recommend all of you who are planning your career should read, Ikigai. It is easily available and it is quite popular. Many of you might be known also. So according to this, if a person decides on what to make it as a career based on these 4 questions, like what you love. So what you love is what you enjoy doing, what you are fond of doing, what you enjoy, what you like doing. Second is what the world needs, like what are the requirements of the community or the society where you are working in, what are the kind of needs present. Third one is what are your inherent skills, what are you good at, what you can do very well and very easily you can. And the last one is what you get paid for. So if you know these answers to the 4 questions listed here, it helps you in making a career choice. So you can note down this and you can think about them when you are free and try to identify areas which match all the 4. Then if you go for that, I think it will help you a lot. This is again the diagram explaining the same thing. It may look a bit complex, but if you just watch it properly, you might understand it. So there are 4 questions, 4 broad themes. Like first is what you love over here, what the world needs, what you can get paid for, what you are good at. So if you have all the 4, if you can find an area where if you work and all the 4 can help you, all the 4 questions are taken care of, then that becomes your ikigai, or that something which you can strive for and that can become your life's aim. You can succeed really well in that area. And then the second is what you love. So what you love is what you enjoy doing, what you are But it is possible that you might be doing something right now which is what you love and what the world needs, but probably you are not being paid for, cannot earn for that. Like this is done by very few who are like missionaries like Mahatma Gandhi or Mother Teresa. Like they were superhumans, I would say, in a way. Like they didn't need they didn't care for the money what they get, so what they got, so they could do all that. So it's a delight and fullness with no wealth. So then you may need to take care of other things. There are people who might be getting paid for things and they are addressing world's needs, so they are in a vocation, but they are not very good at that. So you are getting your earnings, but you don't have a recognition. Like people don't know you as someone great in that field, and it is something probably do not enjoy. So then you will not be so much satisfied for it. Then there are people who are good at something and they are getting paid for also. They classify it as a profession. So like a chartered accountant is good at accounting and he earns a lot of money. But when asked whether you love that, he may not have any answer for that, or whether he's addressing any world's needs, any purpose he's serving with that, then also he may not have any answers. Then he will be kind of unsatisfied. Like again, coming to what Dr. Rao said, that a specialist might be good at doing something, he might be getting a good income for that, but whether he's addressing a world need, then I don't know. Then that creates a vacuum inside, and then you feel unsatisfied at the end of the day. And similarly, you can work out many permutations, combinations. I will move on because we are running short of time. So that's how you decide on purpose or on your career. Now we'll talk of our journeys so that you can. I don't know what you will enjoy it or not, but maybe it might help you. So we'll start with Sejal here. Sejal, you can come on now and share your journey from here. I can move the slides.
Yes, thank you, Shyamsundar. So, hi, I'm Sejal. I did my MBBS, and as everybody does the specialization, I was also involved in the rat race, and I did my MD in physiology from JJ Hospital in Mumbai. Can we go on to the next slide? Yes. So after doing physiology, I really did not think of doing any teaching. I mean, I did not think of getting into the teaching profession. So me and my husband Nidhin, we both were fond of roaming about everywhere. So there was an opportunity by Helpage India in 2013. Kedarnath had a very big flood disaster. So we got a call. Doctors were needed there, and so we decided that why not try working with Helpage India, and in a place where nobody is knowing us, and we also don't know what kind of challenges would be faced there. So we went there to volunteer for 15 days, and we fell in love with that place, and we continued working there in Chamoli district of Uttarakhand for almost an entire year. This was the mobile ambulance in which we used to travel to different villages. It was beautiful around, and we can see that in the next slide. The ambulance used to go to multiple villages. I used to go in one of the ambulance, and Nidhin used to go in another. As you can see in this photo, we used to park our ambulance at the base of the mountain. Then the villagers would come from the mountain. They would. It was a general health care. I mean, they would come for n number of problems like uh, aches and pains and fevers and coughs and colds and many more than that. Maybe some serious illnesses also, which we could just screen through while being in the mobile ambulance. I am very happy to show you that when we were working in the ambulance, we could see the Himalayas behind. So being very much curious, we went to see the Himalayas from the nearby side. Every Monday to Friday, we used to work there, and Saturday, Sunday, we used to trek to see the Himalayas from a really nearby distance. That had become our passion. like to work for the whole week and then to trek during the weekends. And that is how we loved working in in Uttarakhand. This way 1 year had passed, so we decided that we have almost roamed around the entire state of Uttarakhand. Now let us visit northeast of India, because we had heard that it is very, very beautiful. So Nidhin started looking for NGOs working in northeast of India. Can we go on to the next slide? So there was an NGO in working in Arunachal, known as Karuna Trust. Karuna Trust works with the government in public-private partnership mode. So all the PHCs in this one district of Arunachal, in the Tawang district, was given to Karuna Trust for managing. So this was the view from our medical quarters. So this is the mountain where we could see the Bhutan mountains behind us, and on one side we could see the China mountains. This is a photo which is taken at 4 o'clock in the morning. We had an emergency during the night, and by the time we came out of the PHC, this was the view, and it was like just wonderful. This was the first ray of sun that had hit the mountain, and it was just beautiful. Next slide. So this was our PHC Lumla. It was in the Tawang district. So we were 2 doctors there, and rest of the nurses, 1 lab technician, 1 pharmacist, and the local people were the cleaning staff over there. But then we made a practice to actually inculcate the habit of cleaning in all of us. We all every week, once a week, we used to keep the cleanliness drive. So that the villagers also see that, and we also learn working with the local villagers that way. Next slide, please. So yes, after working in Tawang, we got an opportunity to work in Meghalaya. It was with the same NGO, Karuna Trust. So the beauty of Meghalaya is that it rains for almost 8 to 9 months. So this is the road condition after the so many months of rain. So in the PHC, we have to visit sub centers which are part of the PHC, but they are in the interior villages. So to go there, we have to take our ambulance, or we have to take a local vehicle. So this was one of the situation of the road after a heavy rainfall. We got stuck, and we were going with our Ayush doctor, who was also posted with us in the PHC of Saipung of Meghalaya. And this is a beautiful rainbow that we could enjoy. Actually, you can see a double rainbow there. So after the rainfall, it was beautiful. So the main thing is like work was always there. And even after doing a specialization of physiology, which was actually of no use in the primary healthcare, we were still working as a generalist. So during working in the PHCs in Arunachal and Meghalaya, we realized that we need to be in touch of clinical practice, and we also need to upgrade ourselves in terms of primary healthcare. So that is why we did the Masters in Family Medicine course from CMC Vellore. That time it was available as a distance education course. It is still available, but now it is known as PGDFM. And it had 3 contact sessions, which the contact session for us was in Nagaland. So it was an opportunity to connect with other people, with other doctors who were working in Nagaland, to roam about in that area. And that is why we enjoyed working in these primary health centers, which gave us, which made us stay close to the nature, to fulfill our passion also, which was trekking, bird watching, photography. Am I still audible?
Yes, in between you are not audible. Now you are audible.
Oh, I was not audible. Okay, so
For only
okay.
few seconds. Only seconds you are
Oh, only
audible.
few seconds.
Otherwise it was fine.
Okay.
Yeah.
Okay. Okay. Can we go on to the next slide? Yes. So this was in the PHC. This was our water source was a natural river flowing by below the mountain where we stayed in Saipung village. So our water pump was immersed in this particular catchment area. So during the rains, it used to get blocked with mud, and all of us used to come down to clean the water pump so that water can be pumped back to the PHC. Next slide. So this was also a very good activity where everybody enjoyed playing in that mud. Then this was the sub-center visit. The sub-centers were almost we cannot measure distances in kilometers in mountains. So almost 10 hours, 8 to 10 hours of walking distance was the nearest sub-center. So it was a bright and sunny day, and we went for immunizations. Our nurses and community health volunteers were there with us to visit the villages. This was a home visit done for the ANC. Yes. Then after working in Arunachal and Meghalaya, we got opportunity to work in Antarctica. So Indian Antarctic Research Station needs doctors. Every year the expedition goes to Antarctica, and this is the view photo of the iceberg, and one photo is from the plane where we were just landing onto the Antarctic island over there. Next slide. So this is Bharati Research Station. Me and Nidhin, we were posted here. We worked for almost 14 to 18 months over here. So it is a absolutely wonderful experience. Here also, they need specialist doctors, means they need doctors who are trained into anesthesia and surgery. But they also consider doctors who have a vast experience, at least 3 years to 5 years of experience working in resource limited settings. This is the frozen sea, and the ship is traveling on it. It is bringing the supply needed for the entire 1 year of stay in Antarctica. Can we go to the next slide? Yeah. This is the beautiful iceberg. This iceberg has been stuck here for almost millions of years, and slowly it has started melting. Also, here the challenge was that 45 days in 3 months in a year, there was no sunlight. These nights are called as polar nights, and during that time people used to have a little bit of isolation, a little bit of depression, and so that is why our main job used to be to identify people who are suffering from all these things and counsel them. And basic, here also we did not use our specialization, whatever we did, family medicine, and on the basis of MBBS knowledge only, we were able to treat most of the people. And while staying in Antarctica, we were able to do the fellowship in this diabetes course, which was again offered by CMC Vellore. This was also a distance education course, and it was a very interesting course. Can we move on to the next slide? So these are the southern lights which are seen in Aurora. These are the polar lights, which happens because of the magnetic field around the poles. It is beautiful. These are the photographs taken by Nidhin himself, and it was an extremely difficult task to take these photographs because the outside temperature was almost -30, and with a very big wind chill, the temperature felt like it was -60 to -80. Can we go on to the next slide? Yes, this is another photograph taken of the southern lights. This is also known as Aurora Australis. Can we go on to the next slide? Currently, I am working at this TB OPD. It's known as Doctors Without Borders. It is also known as MSF. So here, MDR TB patients are being treated on an ambulatory basis. So this is run by MSF, and it is made made up of containers and the patients are given treatment over here on an ambulatory basis. It is very wonderful. Here also, like, I mean, I think I was recruited here on the basis of my MBBS and my degree. I think my degree in family medicine. Other than that, I think even if we are not a specialist, we are still getting an opportunity to work with MSF and learn about MDR TB. Can we go on to the next slide? Yes, this is Go to the People Youth Camp.
Excuse me. Hello.
Yes.
Yeah, I think someone has scribbled on the screen.
Yeah, I can see that.
Get it cleared. Yeah, I don't know how to clear this. Can the host clear this, or I?
So sorry for this. I'm trying to identify people, the participants, and I've asked a couple of them to identify themselves, and I'm moving them to the waiting room till they identify themselves. So yeah, just go ahead with this while I try to figure it out. Yeah.
Actually, the screen is all scribbled. So how do we clear that?
Yeah. That's
okay. So I'll talk about this. Go to the People Youth Camp. This is the, I mean, this is an initiative done by me and Nidhin and lots of our friends. So now we have, we have founded an NGO known as UMETA Foundation. So here we provide platform for youths who really want to understand the why, what, and how about themselves and the society they live in. So 18 to 30 years age group youth are, invited for this camp. It is a 6 days residential camp. Currently, we have started in Chhattisgarh, and very soon we would be starting it in northeast of India. The new camp for the, for the youths, it will be starting in the month of August. 12th August to 19th August is the date. So,
sorry, Sejal, you have 1 minute
yes.
left. Yeah.
Yeah. Okay. So once we understand that why do we have to live, and once we understand that what we have to live for, if these two questions are clear in our mind, then how to live is not a problem, because it automatically we can make way through it. Can we go on to the next slide? This underneath the scribbling, you can see that this is the youth camp where the students were given a topic based on discrimination, as Ruth had mentioned, and they were discussing among themselves. Can we go on to the next slide? Yes, and as Shyamsundar mentioned initially, that we should follow our ikigai. We should understand what do we love, and what is our what is the need of the people, and what satisfied us. So all that I mentioned in the PPT, I think that whatever we love is like trekking, bird watching, meeting with different people, staying in the Himalayas. I think we have followed all that things up to now. So I can say that we have followed our ikigai. This Annarai is another community living venture that we have started. So this is a entirely a mud house built by one of our friend in Igatpuri in Maharashtra. Everybody is welcome for that. We have our own natural swimming pool, which is almost 5 square kilometers in length and breadth. And this is a beautiful place where we can just sit underneath the stars and do stargazing. During the monsoon, it is beautiful. There is it is nearby to the highest peak of Maharashtra, known as Kalsubai. And with this, I end my presentation and my journey. And I ask Shyamsundar to continue with his journey. Thank you.
So, Shyam, I don't think you have time, but do you want to summarize with one slide?
Yeah, sure. So,
thank you.
What I wanted to talk of is, so these are some key takeaways from my journey, which I wanted to share. Like, it is a bit similar to Sejal, like, but what I could do is I was in professional career for 10 years, and then I took a break of 1 year because I wanted to do something else. Was to explore my surroundings and explore our country and our rural India, and also to follow my passions during that time. So it kind of recharged me and gave me a lot of time to reflect and think. So these are some takeaways from my journey. I wish I could share that, but so one thing is that first you need to find out your why and not somebody else's why. Like why you want to do something. Like even if you are to say public health or primary health care, it should not be that you want to do this because you want to serve a community. Because then that why is cornered around someone else. Like the why, better why would be that I want to do this because I enjoy doing this. If you have that statement as your why, then you are doing it for yourself, not for somebody else. Although your acts and your work will help someone, but that is not your primary aim. It is for yourself because you enjoy doing this, and it will give you fulfillment. Second point was that being in rural India for almost a year and meeting so many people, I felt that it was a very fulfilling experience. Like it brought a lot of positivity to my urban areas. Will always complain about financial viability, patients suing them, or like the insecurity what they had. But as compared to rural area, it was a totally different picture. I could be close to nature. I could enjoy rivers. I could climb mountains. I could do many things which I like. And one important thing is that I was not alone. I realized that there are many people like me who have ventured into such areas, and they are ready to help. Even now, the connections which I made during that time, I can always approach them, and I just lift my phone and just call them. So it is quite helpful. I get part of a community now. And what I did was not to get another degree or to gain one specialization. Yeah, I tried to do a skill diversification. So that were key takeaways. And last slide of our presentation, it is just the last slide. It is not a dichotomous situation, like it is not either or. You can be a specialist and try general practice. There are doctors in tribal health initiatives which you can go and meet them. And there are many others. Keep those 4 questions in mind while you are making a choice. And finally, like I mentioned, you can go and explore them. There is a travel fellowship, sensitization, there is MR in search. You can go to places and experience and find out what you want. Yeah, that's it from my side. This is the last presentation. If one plan doesn't work, there are many other options out there. Thank you.
Okay, so thanks a lot, Shyam and Sejal. I'm sure you have ignited many minds, and or you have added fuel to. Can you hear me? Hello?
Yes, you are audible. Yes.
Yeah. And I'm hearing more people than myself. Okay. So, so that brings us to the end of the speaker sessions. Now we will move into the Q&A. So one thing is clear from the blinkers or blinders which the horses are made to wear. There are so many possibilities, and as Shyam has shown the diagram of Ikigai, if we can follow that, and I think it's a constant journey, it's a continuous journey. So there will be a Venn diagram that fits in at some point, and it's dynamic. So coming into the Q&A session, I'm going to introduce some more stellar people here. We have Anand Zachariah who is one of the most respected professors at CMC Vellore, specialization in internal medicine, but I will say that he actually stresses on internalizing the values of medical practice. So I would say he's a specialist in that manner. He is also an excellent student mentor, and his interests are in exploring, in running, outdoors, travel, and poetry. There are so many CMC Vellore influences in this webinar. I'm not getting any honorary degree, although I wish, but it's just I'm learning that everyone has something to do with CMC. And then we have Shilpa Khanna. She is a graduate from Maulana Medical College, Delhi. She has studied anesthesia, but has worked in rural central India in Maharashtra and Chhattisgarh for 5 years. She got, and not as an anesthetist solely, she got interested in providing services in pain management and palliative care and got trained for the same. She has currently established pain and palliative care services in the public health system in Sarguja district in northern Chhattisgarh. Her husband, who's Chaitanya, who's also a physician, involved in primary, secondary, and maybe even tertiary level care in rural Maharashtra and Chhattisgarh, and their young son have been part of her journey. And I'm stressing this because sometimes this is an issue for people, like what about the family and what about the children? So there are people who are doing it. Shyam is another example with a young son. So Shyam and Apeksha are handling that beautifully. Then Shilpa's interests are in reading, baking, and gardening. Then we have the youngest entrant or the youngest participant. She is Divya Manchanda. She is from 2015 MBBS batch, currently pursuing her Rural Health Travel Fellowship. And this is a one-year fellowship platform offered by about 10 rural healthcare NGOs. And Divya is currently also in Chhattisgarh, in a place called Jana Swasthya Sahyog. She is also doing a course she's enrolled in this fellowship of being a PHC leader. So it's a PHC leadership fellowship program. And she has a short stint experience of working in a PHC in Rajasthan. So we have these 3 new people, and I would open the floor to people to ask questions. And I'm hoping that my colleague Nidhin has been keeping a track of people asking. I see some hands raised, but I'll let Nidhin ask questions or direct questions to people. So yeah, we have all the previous speakers.
Yeah.
Ruth and Shyam, Sejal, Dr. B.C. Rao and Devadasan, and the 3 new people, Divya, Shilpa, and Anand Zach. So thank you all. Yeah, Nidhin.
Yeah, thank you everyone for the wonderful talk, and thank you, Vasu. And so regarding the questions, should I start with the written questions first, or should I take the people who have hand raised?
As they come. So if whatever came first.
Okay.
Yeah.
So I think we should go with so some of the one. It was not a question. It was one of the person has asked, kindly give the details of family medicine course and about the duration of the course and the exam practicals. So the link has been given by Shyamsundar regarding details of family medicine course in the chat itself. And regarding the family medicine course in CMC Vellore, that is PGDFM, and the MD in family medicine course also with the links. So if anybody else want to throw some more light about family medicine, so any of the panelists, please.
Good evening. I am Dr. Ilamanthi, Professor of Pharmacology, and I am doing my family medicine course in CMC Vellore. I belong to 2019 batch. I just want to tell those who are aspiring to join the family medicine. First of all, it's a very, very well planned and wonderful course, provided that you spend time in going through the booklets and the contact programs, regularly attend the sessions, everything. I mean, you need to be very meticulous. I mean, I find it a little difficult with my professorship and with my family and family medicine, but still I try to meet the ends. And it's actually initially what they ask is, I mean, why do you want to pursue this family medicine? Like, you need to give an intro, and if they are satisfied with your intro, they select. And it's, I mean, previously when I joined, it was 250 seats per year all over India. And we have a national group as well as the Chennai group, because I belong to Chennai. And as I told you, I mean, if you can give your time and if you can dedicate in the course, really you will learn a lot. And the course fee that time, it was 90,000, and it's a 2-year course and 3 contact programs. And initially it was scheduled 11 days for each contact program, but because of the COVID, now the 2nd and 3rd contact program we are ready to attend, I mean, in July. It's reduced, and you have 2 exams, first year exam, which has a theory exam as well as practical exam. Apart from these first year and second year exams, practical and theory, you have assignments which you need to submit online, and it is time bounded. And during the contact program also, you have, I mean, a test every day before you begin the day. And you have to submit 2 projects. If you are practicing, like I am not a practicing doctor, though daily 3-4 consultations I do over phone for my relatives, friends, all over phone, because I mean, none of them none of them are near me. And from those 2, I mean, from those cases, I took 2 projects. One was carpal tunnel syndrome, and the other was Krebs typhus. And you need to write the project according to the, like our usual dissertation, with the references, with introduction, I mean, a review of literature, everything. It includes everything. And particularly the family medicine protocol, if through CMC, you need to apply the genogram and many new things which we learned during our course. You need to apply it in writing your project. So, I mean, I will suggest and I will advise anybody who, I am 55 now. I mean, age is not a bar, and anybody who is willing to join this course, it's a wonderful, I mean, generally CMC is wonderful in everything, but this is also a very wonderful course. Thank you.
Thank you, ma'am, for the information. Any of the panelists?
Nidhin,
Yeah, please.
Yeah, so the motto of the course is refer less and resolve more. Refer less and resolve more. It comes from the person who started this course. His name is Dr. Vinod Shah. So he worked for many decades in rural area and found that there was a lack of primary care providers. So the majority of doctors are in the urban areas, and those who are in rural areas are not trained to be primary care providers. So he, though he was a specialist in pediatric surgery, designed this course to use the distance education as a lever to train large number of people to provide primary care in needy areas and therefore address the imbalance. So this course is very strategic, like a public health intervention to train large number of people. And I think so many people here who have spoken, quite delighted to know that you have done this course and it is really helping you in so many ways.
Thank you, Anand. I think I could not see any other relevant question. Vasu, is there any other questions?
There was one Mathu who had a hand raised.
Yeah. Mathu, can you please ask the question?
And then I have a set of questions after that. Yeah, for different. Okay.
Mathu, are you there?
There's one person, Venkatesh. Okay, we can skip to Venkatesh.
Venkatesh, can you ask your question?
You can unmute yourself and also ask.
Yeah. Yeah. In initial speeches, what was said about all the discrimination encountered by the graduates who get and work in rural areas or tribal areas, and get to know about how vast the difference is, what medical colleges do not teach. Now that in the last decade or so, we got primary care providers and healthcare providers also, and family medicine also. I'm just trying to look at how could this gap can be bridged, where community medicine department can link up with these initiatives also. Is there any tried out examples so that we can start looking at this direction?
Any of the panelists can answer it?
Venkatesh, do you want someone in particular to answer that question? Like that's one of the speakers?
I mean, in terms of, I don't have any specific speaker to be addressed. Anybody could take the call. With those who have worked with the primary care, family medicine practitioner, as well as they've also. Now that I know
Dr. Rao can.
Yeah, I think I'll take that question. So, this is really a very difficult question to answer. Simple reason, social determinants of health, they are, very, very culture related. Our country is still to come out of these cultural inhibitions that the community has, and I even know that even the doctor community has. To treat a patient as a human being with problems and not belonging to this community, this caste and this income and that is something that you will develop, you should develop in the course of your life. It can't be taught, but in medical colleges at least, you should teach students, and the humanities, that subject has to be taught as a part of their curriculum. And see, sometimes, in my medical school days, I thought preventive medicine is a useless specialty. I realized over years that's probably the most important specialty that one should learn. Similarly, humanities is a very important aspect of our lives. But then, it can't be taught, it has to be experienced. And a good doctor will learn to treat a human being as a human being with no other aspects of his life to be taken into consideration. I think this question cannot, you have to solve it yourself and understand it. And that is not easy, but it is possible. All doctors should try to do this.
Can I come in?
Deva, before you, the Colonel Ubendra had his hand up, so I think he wants to comment on the same thing, unless he has a question.
Hello, can you all hear me? I'm Colonel Dr. Mohan Kubendra. Actually, I couldn't hear most of the session. I had messaged in the chat box also. There's some problem at my end, but I hope you all can hear me.
Yes.
Okay. Firstly, I must congratulate and my sense of appreciation from the Academy of Family Physicians, which whom I represent, for organizing such an event targeting the medical students. So the medical students are always in dilemma whether to take up specialities or to take a generalism. So from that perspective, I think this session was really useful. I just wanted to come in because a lot of worries on whom to connect with to know about the family medicine courses. So we represent the Academy of Family Physicians of India. I am the National Vice President. So we have the state chapters. So we can get it. They can get in touch with us, our state chapters, for any queries on family medicine and the family medicine courses.
Okay, so thank you. And sorry, Dr. Deva can come in. I guess you want to add to what Dr. Rao said, yeah? Yeah.
See, I think, as Dr. Rao said, essentially, we are not, I mean, we as doctors are trained to be super, we are told that we are super men or women, and we are much higher in terms of power, etc., compared to the patient. And we go through medical education and our specialization, and later in our practice also, we are it is ingrained that, oh, you're a doctor, so people put you on a pedestal, or we ourselves put ourselves on a pedestal. Unfortunately, I think today when we talk of the violence against doctors, this is actually a reaction to that, where people we will not be treated as can you hear me?
Yeah, now we can hear you.
Okay, so there is anger among the patient community as well as this thing, because they want to be treated with respect, they want to be treated with dignity. But as doctors, most of us, I mean, I've traveled all across the country, we take our patients for granted. We don't even dare, we don't even close the door of our OP, this thing, while examining a patient. I mean, so, but things are changing today in the maternity circle. There is a huge movement towards respectful maternal care. And I've been following that up, and I've seen that wherever the this respectful care is taught by people who actually believe it and practice it, and there's a role model, then the nursing students follow them. Whereas if you just talk about it in the theory and classroom, etc., there's no change. So I think what we need in our country is more role models who practice this sort of respectful care for the doctors.
Yes, absolutely. Thank you for that. Now I have two questions for the two women I had called for for this session. One question is for Divya, who's the youngest amongst us. The panelists. Are you still confused? That is the question for Divya, if she's still around. And then there is a question for Shilpa. I don't know if she's still around. Let me see. Yeah, that let me read out. Do you have to mold yourself for your partner, being a woman and as a mother, or are you able to follow your dreams independently? So is it more of a sacrifice for this gender? So one question is for Divya. Are you still confused? Or you think you've made the right choice for this moment of time? And the question for Shilpa was related to gender equality. So Divya, if you're there, you want to go first?
Hi everyone.
Yeah. Hi, you can, yeah, go ahead.
To answer your question, I don't think I'm confused now. I mean, as sure as I can be. I don't think I'm as confused as I was when I started the fellowship. But yeah, I mean, one thing I've learned from my journey, like the reason I came out of a medical college was because I wanted to see, because what we did in medical college was treat people as patients rather than people. And I mean, even in a hospital, I could see a person removing his chappals to get into a room where everyone's wearing shoes, which was something like represented the caste barrier that we have created in our, that had already been there in our country, which I could see here as well in some respect. I mean, we have been put on such high pedestals that like I think that every medical graduate should be put in a rural area for first 3-4 months of his medical education, to fetch water, to cut woods and whatever. But yeah, I mean, that is why I joined the fellowship. And I think at this point I've realized that what I should be doing once I finish this journey. So.
Thanks a lot. Very important points in the beginning also. And the next question about how difficult it is to be a woman and a mother, to Shilpa, and follow your dreams.
Yes, hi Vasu. Thank you for this question. very relevant, I would say, not among only doctors and primary care practitioners, family medicine, but not even limited to doctors. It is an issue that is being plaguing our society since the beginning, isn't it? But I would say that I have been very blessed with a partner who has been my friend since my MBBS days. And he, although there are things that are very passive, that don't actually, cannot be seen from an outside perspective, this gender inequality. But I have realized that people have become very sensitized about it. Why? Because we have started talking about it. So once we start talking about something, you will, and you truly reflect in your mannerism, behaviors. So you get to, notice little things that are, that bring in all the difference in your perspective or your behavior, even opportunities. So we talk about it a lot. We have, as Vasu, you already know, we have started an organization here in Chhattisgarh. So this gender equation plays out here as well in the organization's, EC or even daily activities. It plays out. But we try our best to be as gender sensitive as we can be. What we can do as a generation is that we talk about it with our kids. So even from the beginning, that there are more sensitive cartoons per se, like the mother is also driving, mother also goes to work. So these little things and will matter. I personally, I would say that I have not sacrificed a lot. It has been relatively quite easy for me because my partner was such that every time I had any issues, he had fully supported me in my career. He has supported me personally. So one thing I would say is that this issue has to be talked by and noticed by both women and men. Women are also not recognizing it. They don't talk about it. We don't talk about it to our kids. So if I feel that if we can openly, talk about these things and bring out through any example, we will be able to, build more equal society. Thanks, Vasu.
Thanks, Shilpa, and I hope everyone is listening to this also, and it's very important in making decisions, and it affects one gender really more than the other, and it's a very silent thing that affects people. So any more questions? Nidhin, do you have any more questions? I have a couple of them. Yeah, okay. We have one hand, Venkatesh. And then we are almost, we'll probably extend 5 more minutes into this and close after that. Is that fine, Arvindan?
Yeah, thanks to the organizers for having conducted this thing. But in terms of what I'm worrying is, unless until we address the basic, to say, the existing infrastructure of what medical colleges are there, this differences of how a doctor puts into his or her practice of, and that creates a discrimination, will remain to say. So if you can try to see that this aspect, preventive and social medicine departments can take up initiatives, and by tying up with family medicine and many other things which are trying to work up in their own silos, and then we network each other and try to see how best we can maximize, and then try to association and network. I see there is a possibility of getting the primary healthcare practitioners back on track.
Any comments on that? Anand Zach?
Arvindan has a question for Shyamsundar. So Arvindan, you can go ahead, please.
Yeah, Shyamsundar, I have a question. So when we talk to young doctors who are in the late 20s or early 30s, the question of viability comes up about raising the children in rural areas or resource poor settings wherever they work. So how do you handle this?
Yeah, so that came up with us also. So part of one of the purpose of for us to take the gap year was to travel to these places and know from people what they have done for their children. So like there is THI and there is Seva Rule in Gujarat, and there are many NGOs where they had children and they brought them up. And also because of our interest in understanding education over the last couple of years, we realized that there is a growing community of people who are exploring different ways of educating children. And when we talk of education, we generally think of one thing is schools. So there is a lot of learning which happens outside the schools through lived experiences and through different activities. So what we have decided is a kind of a hybrid approach for our child. Like we are in a remote location in a tribal district. So we'll send our child to the government school over here. And at the same time, we will do many things for the child, not textbook teaching for the child, like will not sit with him and make him do homework or write things, but we'll design activities and learning experiences for for our son, which will create inquisitiveness in him, which will create creativity in him, and which will help him enjoy the nature outside his body. So, and there is a huge movement going on, coming up in our country and also in the States, and about unlearning, unschooling. So I think those are some of the ways.
Shyam, I remember in Hyderabad conference, someone spoke to you, and when you were talking and he asked you this question. And I think it applies to lots of us. What you said makes a lot of meaning. I think a lot of youngsters who are raising their families should understand.
Dr. Rao, you are muted by somehow. You are not audible for last 10-20 seconds. You are not audible.
Yeah, what I said was in conference at Hyderabad, doctor asked you this question that you have decided now to settle in Gujarat, remote area. How are you? What are you going to do with your son? And the answer that you gave then and now resonates with me. And education is not just going to school and doing rote learning. And what you said makes a lot of sense, and most parents should understand.
Again, you are muted. Okay. Yes.
No, I said this is the right advice you gave, and most parents who are listening to you should follow this advice. And I'm pretty sure I have come across some families who have done what you have done, and those children have done very well in life.
Yeah.
In quality of life, I'm talking about. So it should not deter doctors to pursue a path which you and others today have followed. Very meaningful and very, in my view, very successful.
So thank you. And we had two hands up. One was Devadasan first, and then Bodhisattva, then Sarma. After that, we'll close this. We have gone over 5 minutes.
I don't know. I think Dr. Rao said what the thing. So it's an important concern for, especially for young parents. And I don't think there's a ready answer. We don't have answers. But one of the things I've seen, just want to share, is a lot of parents, not doctors, but parents who are working in the rural areas, etc., have started this thing of homeschooling. They register their children with NIOS, and NIOS has quite a good syllabus comparable with CBSE, and they do homeschooling. And I think that is something that those who are this thing can consider. Yeah, I'll stop here. Yeah.
Okay, thank you. And Bodhisattva is the next person, and then we have a few unanswered questions on the chat, which doctornet can probably note down and they can send the email. Yeah, Bodhisattva, whoever that person is.
Thank you.
Yeah.
Thank you. Am I audible?
Yes. Thank
you. Thank you. See, one situation what we are facing now is the students during their plus 12 level, they are focusing extensively on the joint, and after that they come to MBBS and like that. But the sensitization for this medical fraternity is quite lacking for the initial major phase. And sometimes it is even seen that after a couple of years, they realize that they don't like this because of some reason or the other. So what my point is, just like we have a huge requirement of non-critical medical requirements, what has been discussed for this during this webinar, that it may not be requiring a specialized or a very specialist approach, but it is a community approach where the mass requirement is much more. Similarly, another part is the criticalities where, like in a road accident, we need a good first aid. So if we can include this first aid and similar activities in the school level as a part of their curriculum, these students will not only get a hands-on and they will have a feeling for this, they will also, if they don't like, there are some students who have problem in seeing blood. They have some problem when they see people injured very vastly. So this, they can also get alerted that no, this is not my piece of cake. I can move out of this as a career, because afterwards it becomes unfortunate for them when they realize in the reality that medical fraternity requires many kind of special dedication and situation handling, which they might not be prepared, or they might not have the ability to cope for some reason or the psychologically or somewhere. So is it possible to include, just like you're focusing on the community medicine, is it possible to include this as a part of the student activities, that they will come across even like in a basic first aid, the blood donation camps, the basic anatomy, so that they get a chance to have a hands-on during their early school life. I mean, the early 10, class 10, 9, 10, like that. Yes.
Okay, Dr. Zach, this reminds me of what Dr. Raj started, 30, 40 years back, the school health education. Do you want to say anything about that, the Kuti doctor? This is the last question, and we had a question from one Prema, but I'm sorry, we'll have to close it. But Anand, do you want to talk about the school age group exposure to health? And you are on mute.
Vasu, you should say. You should say about Kuti doctor. Please do.
Okay, so it's almost similar to what your ask is about sensitizing children from the school level. And I really respect one doctor in the South, one Dr. Rajkumar Ramasamy, and I can tell that he is my epitome for even family medicine, for community medicine, for all those kinds of things. And he is a visionary who nearly 30 to 40 years back started this school health education program, which is not looking at teeth or measuring hemoglobin, which is actually sensitizing school children starting from class 3. So 3, 5, 7, 9, 11th grade students into different aspects of healthcare, including even the determinants of health to some extent. And every year, and it's the intensity or degree of difficulty is different for different grades. There are about 30 topics of health related topics taught to the school children. About 60 schools are doing this program in the foothills of Kodai and Otan Chatram, if people are familiar with that. And there are health educators, not even doctors, imparting this knowledge to the school children to make them aware, to sensitize them, because health is such an integral part of daily life. At the end of 1 year, to make the children feel good, they get a certificate and which says you're a Kuti doctor. Kuti in Tamil means small, little, to make them feel proud of that. And even after every class, they get some homework, some simple homework is given, and they'll get a star when they come back with the homework. But it's not competitive really. And I've actually sat through 10 classes of these sessions. And it is unbelievable the way the thing is imparted and how much goes into the children. The success is that I have met the principals, and they said that, the children were so bored with our physics class, chemistry class, and they are so interested to know this health class that we have started having our physics, chemistry class after their class, after this health education class. Very interactive. And then what has happened is the children are so aware that they are able to detect, say, diabetes or hypertension in their family, or even know how to administer ORS, even know the difference between mother's milk and infant formula. Even a class 3, grade 3 student knows. It's that kind of thing. It's something worth seeing. Seeing is believing, and sitting in the class is also. So yeah, things are happening, and we are hoping to spread that, like next week itself, actually. The same concept we are going to start in Rajasthan, in this place called Basic Healthcare Services. They are very keen on sensitizing children at a very young age. Similarly, I'm trying to do this in Jharkhand, so that next week will be my first session in a school in Jharkhand. So definitely, I'm a total believer in this sensitizing.
In fact, another point to add here is that the reading of various prescriptions, like what is the TD or BD mean? What exactly is, so when they see a piece of paper called prescription, it should not appear Greek to them.
Yeah.
Always should have a basic idea of how to interpret and what exactly is written.
Okay, so I think we can go on and on. This is a very interesting session. So I'm going to close it. Am I just taking it from you, Arvind?
Yes, please. Go ahead.
Okay. So for all those who have lasted this long, say 32 minus 10 of our speakers and friends, I will again quote our past former president, Abdul Kalam Azad, who used to say that the sky is the limit. And he was also very encouraging to students. So his message, especially to the young people, is to have courage to think differently, courage to invent, to travel the unexplored path, courage to discover the impossible, and to conquer the problems and succeed. And these are the great qualities that they must work towards. He also said that if we look around, the universe is with us if we are willing to work hard. So we look around, and with the lens that Ruth and others have reminded us to wear. So with that, I think we will conclude this webinar, and thanks everyone. Thanks to the speakers and all the attendees. Thank you very much. I'm going to close now. Thank you, Arvind.
Thank you very much.
Thank you.
Thank you.
Thank you, everyone.
Okay.
Thank you very much.
Thank you.